Hello, John.
Hi, Sean.
John, I know you, but I guess other people may not know you. Would you like to give people just a short introduction of who you are, and then I'll let people know who I am?
Yeah, so my name is John Barry. I'm originally from Ireland. I've been in Australia for many years. I've been an anaesthetist up at the Cairns Hospital now for the past 25 years. And for the past few years up there, I've been the on-site principal investigator for the hip fracture registry.
And my name's Sean McManus. I've also worked in Cairns. In fact, John was one of my supervisors. And for the last number of years, I've been on ANZHFR College Council with the role of Pair for Medicine. And I guess John and I have also shared a role on the Australian-New Zealand Hip Fracture Registry. And we're here just to have a bit of a discussion about analgesia for fractured neck of femur, but with particular emphasis on what anaesthetists can do to improve that for our patients. Which I guess leads me on to the first question, John. Do you think we're doing a good job at the moment in this area?
Well, I think we're improving all the time, Sean, but we're not perfect. 40% of the hospitals in the last report did not have a documented assessment of pain within 30 minutes of the patient arriving in the hospital. And so I think elderly patients with hip fractures are at risk of being undertreated for pain. And the importance of decent pain management is now well established. For patients in pain have a higher risk of delirium, they're slower to mobilize, and they have a longer hospital stay. Good pain relief can be challenging in this pain group though, especially pain and movement, and especially in those patients with cognitive impairment. Firstly, assessment is often difficult. Patients with cognitive impairment are less likely to complain of pain or request analgesia, and are therefore at risk of being undertreated. But there are many tools available now to assess pain in these patients, such as the pain assessment in advanced dementia. I just say though as well that pain assessment must be a continuous process to meet a patient's analgesic requirements. It's best to repeat these assessments at regular intervals.
And John, it's interesting, when you speak about that, you speak from a point of view of some expertise, but I guess for people who aren't anaesthetists, sometimes all the different alternatives of treating pain can be quite complicated. I mean, what's your view on all of the alternatives that we have for pain management, particularly with these patients?
Well, one of the mainstays of our acute pain management is multimodal analgesia, including IV-PCA. But the drugs used in these regimens have greater potential to cause harm in the elderly, and particularly in the context of renal dysfunction, NSAIDs are often contraindicated. And although there's little data, tramadol has been associated with confusion and delirium. And also, patients who are confused should not be given a PCA. And so you're often reduced to Panadol and PRN endone, which is clearly not sufficient, especially for movement pain. And opiates themselves are not without their own issues. They cause sedation and constipation and may also be associated with delirium. And that's what makes regional blocks so attractive. The best form of analgesia in this group of patients is a block and timely surgery.
And I guess, from an anaesthetist point of view, there's many advantages of blocks, but for those people who maybe don't have as much expertise, they seem a little bit complicated. And I'm just wondering, what are the big advantages? Why are we so keen as anaesthetists to promote the use of blocks, John?
Well, the first thing is that regional blocks work. They provide excellent pain and movement, and they also reduce the consumption of opiates and may reduce the incidence of delirium and pneumonia, and even shorten hospital stay. And femoral nerve blocks and Facilica blocks have become the most popular. So just going through those two blocks, you can use a femoral nerve block, but ultrasound is the safest way to do it. And this, of course, requires training as well as equipment and experience, especially as the femoral nerve often doesn't show up well in ultrasound. It can be injured performing this block. Alternatively, you can use a Facilica block. These are just as effective as a femoral nerve block, and they are safe with a very low incidence of neuropraxia. They're also quick and easy to insert and can be inserted by nursing and paramedical staff. In fact, they have been the standard block inserted by our APS nurses since 2006. Now, the aim is to place local anaesthetic between the femoral and the lateral cutaneous nerve of the thigh, just below the inguinal ligament. You insert the needle a third of the way along a line joining the anterior superior iliac spine and the pubic tubercle. Drop down 1 centimeter and then check that you're well away from the femoral artery. Essentially, you should be halfway between the artery and the ASIS. Now, the beauty of this block and the reason it's so safe is that there is nothing here but fascia and muscle. There are no important structures to hit. We use the double pop technique. There are 2 distinct pops or losses of resistance as you go through the fascial layers. And this is a very easy block to learn, and you don't need ultrasound. Now, one of the criticisms of nerve blocks, though, is that they only last for a finite time before wearing off. And then you're back to square one. But the patient is now is sort of likely to be up on the ward where there's a lower nurse-patient ratio, and pain relief may not be immediately available. And one answer is the fascia iliaca catheter. You use an epidural needle when performing the block, which incidentally makes the pops very obvious. And then after the initial bolus, you insert a catheter through the needle and use this to prolong the block. And we've been using these catheters for over 15 years. An infusion of local anesthetic won't work though. You need a bolus to give you the spread and to block the femoral nerve. And so we use an intermittent bolus program, 20 mils of 0.2% ropivacaine 3 hourly. And this way the block can be run until the patient goes to theatre, and then we remove the catheter before surgery.
That's fascinating, John. It sounds from your description is that you as an expert anaesthetist, you are advocating that non-anaesthetists really think about using this technique. So it's more than just us in the operating theatre or limited to us anaesthetists working in sort of tertiary hospitals. Is that something that you think is feasible for it to be used a bit more widely?
Yes, I agree entirely with you, Sean. A fascia iliaca block is a particularly good block to use in ED, and it can be inserted by junior doctors as well as advanced practice nurses. And it gives very good pain relief on movement, especially when these patients are being x-rayed and transferred up to the ward. And indeed, in the last report, 76% of patients had a block before surgery. And I would say that many of these were inserted in ED. As well as this, 40% of our patients are transferred from other hospitals, and almost without exception, they all have a block before making their journey, before transfer, which makes their journey much more comfortable. I would think overall then that a fascia iliaca block is effective, it's safe, as well as quick and easy to perform, and can be inserted by nurses and junior hospital doctors, and even possibly in the future by paramedical staff before the patient even gets to hospital.
Oh, that sounds excellent, John. And I would assume that there are resources around both online and within hospitals for people to learn this block.
Yes, there's lots of information out there, and one of our ED consultants has just recently, about 2 years ago, set up a training program at our hospital, and I'd be very happy to share that information if anybody wanted it.
Oh, thanks very much, John. That's great.
Thank you, Sean.